everybody on this warm, warm day? Yeah? Thank you, Dr. Dudley. Appreciate it. I know most of you all. I'm Amy Kageals. I'm a practice director at Carilion Children, and one of my houses is pediatric therapy, and I myself am a pediatric speech pathologist. So we are thrilled to talk to you all this morning. Hello to everybody on the phone out in the warm world. So I have no affiliations, I'm not selling anything. So we're going to talk to you all about innovations in pediatric therapy and talk to you about our evidence-based practice and some new initiatives that we have going. So those of you who work in inpatient, I see lots of inpatient faces, you know what we do on a daily, right? You know you work with us side by side, and then you refer to outpatient therapy. And what happens in outpatient therapy? So this is actual patient visits. This shows, 2,800 kiddos that we saw FY18. We're pretty busy. Well, this is our outpatient. That's visits. So that's 10,000 visits in outpatient. What are you doing with all of those kids in the outpatient settings? So today we want to take the opportunity to highlight for you some of our innovative evidence-based practices in our outpatient settings. This is our general practice area. We have inpatient, we have outpatient, early intervention, that's our home-based natural environment setting for kids birth to 3. And inpatient, we've got the NICU, we've got peds, PICU, PACU. This is our outpatient. This is what we do in outpatient. It's huge. So today we are going to talk to you about some exciting things that we're doing. Tara Floyd is a pediatric speech pathologist, and she's going to talk to you about listening and spoken language for our kiddos with cochlear implants and profound hearing loss. Then we're going to have Ashley Feuerstein. She's our rehab supervisor, and she's going to talk to you about functional E-stim. After Ashley is Kristin Winslow. She's one of our pediatric speech pathologists, and she's a certified neonatal therapist, and she's going to talk about one of our newest initiatives, FES, our fiber optic endoscopic evaluation of swallowing. We have Lauren Maxwell, who's going to talk to you about hippotherapy. She's one of our physical therapists. And Laura Alexander is our team lead, and she's going to talk to us about serial casting. And then Samantha Litz is a speech pathologist. She's going to be running here in the end, and she's going to talk to you about our Baby Bridge Clinic. All right, Tara.
We're off to a great start.
Good morning. Auditory verbal therapy involves teaching children who are deaf and hard of hearing to develop listening and spoken language through the use of cochlear implants and or hearing aids. So I'm currently in my second year working toward listening and spoken language auditory verbal certification, and this can be obtained by an audiologist, a speech pathologist, or a teacher of the deaf. So in the case of a speech pathologist, one would first have a master's degree and complete a 9-month clinical fellowship, and then 70 hours of continuing education in this field, 10 hours of structured observation with certified individuals, 900 hours of professional experience with auditory verbal therapy in a 3 to 5 year period, mentorship by a certified professional in which they must observe or view at least 20 sessions and provide feedback, and finally a passing score on a written examination. There's no one in the Roanoke Valley who is currently certified, and the closest one is at UVA, and so Carilion Children has recognized this need and been very supportive in this process. So some principles of auditory verbal therapy, listening and spoken language. The first is to promote early diagnosis of hearing loss with immediate use of appropriate technology to obtain maximum benefits of auditory stimulation. So the Joint Commission on Infant Hearing in 2007 issued a statement called the Early Hearing Detection and Intervention 136 statement, which says that infants should be screened, their hearing should be screened by 1 month of age. Hearing loss should be diagnosed by 3 months of age, and intervention should begin with appropriate amplification by 6 months of age. This is much earlier than before, when children were often not identified until age 3 or even up into 4 and 5 as they were entering school. So we know that the period of greatest neuroplasticity is in the first 3.5 years of life. We are now able to capitalize on that, and it's really important that we are getting that auditory input to the brain, and important that we encourage families to follow up on these appointments so that this timeline can be followed. Another principle is to guide and coach parents to become the primary facilitators in integrating listening and spoken language into all aspects of the child's development. And this is part of all of our sessions that we are guiding and coaching parents. Next, to administer ongoing formal and informal diagnostic assessments and follow individualized treatment plans. And we want these children to be educated alongside their hearing peers, and this is possible with the early identification and intervention with, of course, appropriate services as needed. Some research on the efficacy of the listening and spoken language approach. In this first study in 2017, 2 groups of children were compared, both with cochlear implants. One group was exposed to sign language with a total communication approach. The second group was using a listening and spoken language approach. So Gears et al. In 2017 found that only 39% of children using a total communication approach with sign language achieved, only 39% achieved age-appropriate spoken language, while over 70% of children using a listening and spoken language approach achieved that measure. Next, in 2016, Kaipa and Dancer conducted a systematic review of 14 studies. They found significant benefits of auditory verbal therapy for children with cochlear implants over other forms of habilitation in the areas of receptive and expressive language and speech perception. And Schaffner in 2017 found similar results of statistically significant advantages of auditory verbal therapy over total communication for measures of receptive and expressive language. So what are we doing here at Carilion Children? So first is our CHEERS clinic, which stands for Carilion, Hearing, Ears, Oral Rehabilitation, and Speech. This is a multidisciplinary team consisting of otolaryngology, speech pathology, and audiology. And ideally, children are referred to this clinic as they are identified with hearing loss, and we use a team approach to help the family develop next steps and make sure that the child's needs are being met in each of these areas. We are conducting evaluations and therapy utilizing listening and spoken language techniques. I have served as a community resource for speech pathologists in the school system as well as in early intervention who often have little experience and knowledge in this area, as well as for teachers. And finally, we have started teletherapy, which allows us to provide these services for patients for whom distance is a barrier. And as I mentioned earlier, parent coaching is a huge part of this therapy, and so teletherapy really lends itself well to this so that we can be coaching the parents through teletherapy as they are interacting with their child. Thank you.
As we switch over, does anyone have any questions for Tara? All right. Next is Ashley.
Good morning. I'll just hold it. All right, so I'm going to be talking about functional electrical stimulation. So I'm a pediatric physical therapist, by the way. So functional electrical stimulation is a type of neuromuscular stimulation. So when you're, basically it's a device that's used with electrodes that goes over a muscle and to elicit a muscle contraction. So that NMES is used for strengthening, and functional electrical stimulation is a type of NMES. It's specific to a task or some sort of activity to help improve function for a patient. So common types are to be used for foot drop and ambulation. That's what I'm going to spend my time on today. Can also be used in shoulder subluxation for patients post-stroke. Hand, it can be used for grip and various hand activities, and it really can be used in any area where you can isolate a muscle contraction using the electrodes. So these are some of the considerations that we have to think about when we are considering this for our patients. Usually, the bottom two are not usually issues that we have to handle very often, and we would always be in contact with the referring provider in the event of any of these circumstances. So specifically to foot drop, traditionally we use a rigid brace, like some sort of plastic or polycarbonate brace to basically just support the foot as you're walking through swing phase of gait. So, when that happens, you're not strengthening anything. You're just letting the muscle tends to atrophy and get weaker over time. And so what FES will do instead is use your muscle structures, use what's still there, and will elicit a motor contraction muscle contraction to lift the foot through swing phase of gait. Of course, you have to have an intact peripheral nervous system, so this is really only used for any non-progressive CNS disorder. So here's some of the evidence. The first one is a systematic review that focused on CP. So the effects of functional electrical stim did show a potential towards in a benefit of using that over an AFO. Some evidence shows a decrease in self-report of falls and toe drag. And then there was limited evidence to show improvements in activity and participation. This is another systematic review specific to any CNS disorders that are non-progressive. FES was found to be equal to an AFO. And then in reference to stroke, this is a meta-analysis published in 2016. There was improvements in quality of life, gait, motor abilities with functional electrical stim and therapy. They did not find it more effective when compared just FES to conventional therapy. So that being said, the literature is very limiting, mainly because they're not universal methods to test across parameters. There's limitations to having access to gait labs and things like that in order to show improvements and relate that to function. So here are some of the devices. So on the far left of the screen, this is a neuroprosthetic. So this is a device that basically takes all that wiry stuff on the right side and puts it into one pretty little cuff that can fit over the lower leg of a patient. The red circle is where one of the electrodes that would fit over anterior tib, and then the little box device is how they control that. There's several different neuroprosthetics out there. This is just one example. Everything on the right is what we currently have access to. So you can imagine on a 3-year-old patient, this is a lot of fun. So we would set up the electrodes on their leg, and then that's wired to our little NMES units, little box there with a digital screen. And then there is a foot switch, on-off switch that we have to use that we have to fire as they're swinging their foot through, and we have to gauge every time. You can use a heel switch, which is pictured on the bottom of the screen, but most of the staff that we have couldn't get that to fire, so a 3-year-old is not weighing enough for that to actually trigger to be used. So that's why the neuroprosthetic on the left is so nice. Okay, so I'm going to talk a little bit about a patient that we've been using this on. She was a 3-year-old. She had with left hemiparesis. She suffered a right MCA stroke in utero, and she started PT with us at about 12 months of age. She had some delayed milestones, but really caught up. She's ambulatory. She does stairs, jumps, runs, all sorts of things. And we really found that after using the AFO for prolonged periods of time, anytime she was out of it, we were just supporting this whole toe drag, and we weren't really correcting it, and she had to have the AFO to do anything. So here's a video of her pre and post. Oops. There she is running.
Okay, walk slowly.
So you can see on the left side, I'm trying to give her some verbal commands, so excuse my
Ray, I need you to come back
bossy voice. So you can see there on the left, she's dragging that foot, hips behind, her knees all over the place, her foot's, as I like to call it, wonky. Now here she's got the neuroprosthetic on, and so you'll get to see appropriate toe-foot progression, and her knee is staying in line with her hip. Yeah, she's a squirrely little girl. So you can see here, and this is just the first time she tried on the device. That was the very first time we trialed it. She was 3 years old. Really, to be able to use it, you need a patient who can verbally tell you if it hurts, because you have to get a motor response, and that can be painful. It's nice to have some sort of sensation, because they need to really be able to tell you if it's burning the skin, because skin issues can become an issue as well with the neuroprosthetic because of, just skin wear when you're sending an electrical current through the skin. So what's interesting now, so the family had to purchase this out of pocket, and they purchased this about 7 months ago. She is able to stand on her left foot, do a single limb stance on her left side. She's holding that for about 6 seconds. Previously, it was like 1 to 2 seconds at a time, which is really important to be able to do stairs and that sort of a thing. She had a leg length discrepancy on the left side. It was a lot shorter because she wasn't spending as much time on that side. She's corrected for her leg length discrepancy totally. And then she couldn't pull her foot to, she basically could only get to neutral on her left side. She now has 10 degrees of active range of motion of dorsiflexion. So we really need about 10 degrees to do stairs, or 15 degrees really to get, to do a lot of other more advanced activities like jumping and running and that sort of thing. And so she's well on her way to that, and that's just after 6 months of that device. So that is it.
Thank you. Does anyone have any questions for Ashley? Dr. Keith?
So that would be after on the rock, like drug-induced or...
Can you just repeat his question? Oh, yeah. So he asked if that could be utilized for a peripheral neuropathy. It would probably, we could do some trialing to see if it's something, if we could elicit a motor contraction. If they have sensation, we could potentially use that. We've done it on some patients with Guillain-Barré, and we've done it on some patients that, with those types of disorders. With a fair amount of success, because really, as long as you're monitoring the skin area with the on and off time, you can do it. And we've considered, even on some of our patients that have had chemo and have some peripheral neuropathies with that, we've considered doing it with those kids as well, because it would be nice for them to be able to not trip over their own feet when they're walking and running. So, any other questions? Yeah. The fun question. So the device with all the wires, that whole setup is about $500. An actual neuroprosthetic for one leg can run anywhere from, I think you can get them as cheap as $3,000, but really more like $5,000 if you want the one that doesn't have all that will actually fit a pediatric patient. So.
About the heel switch, is it constantly activated?
So, if you have, so for the wire setup, so he asked if it's constantly activated if you don't have the heel switch. So when I have the button, I can trigger when it fires. The cool thing with the neuroprosthetics now, they're all done via accelerometers, like the things that are on your phone and that sort of thing. So you can actually, it is determining when to fire through gait phases and where the leg is positioned in space. It also can tell, based on the muscle being fired, it will trigger to fire, like how intense the muscle contraction will be. Like, so it's really cool. She's now 5, but she was 4 when she got the device. She can just tap her toe and she can get it to fire and watch her little foot go up and down. So it's awesome. And plus tapping into it at this age, as Tara mentioned, with auditory, verbal stuff, those young ages are so imperative to being able to have neurodevelopment. So there's so much more plasticity we know, and would love to have more research in that area. But it's just pivotal to get into that, to get to them at that young age. And really right now, about 3 years of age is as young as you can do it use a neuroprosthetic on them because of the size of the cuff. So, thank you.
I don't want that one.
Oh, yeah, sorry.
So we're going to switch to swallowing. My name is Kristin Winslow, and I'm going to be presenting today on the use of FES to assess dysphagia in our pediatric population. And up until recently, outside of a clinical or a bedside swallowing evaluation, our only means to assess dysphagia with our little kiddos was a modified barium swallow study. Thanks to Amy for all of the incredible behind-the-scenes work, and I do mean work, and the mentorship of our department head in ENT, Dr. Kageals, we are now performing FES. Myself and Samantha Litz are actually doing this. And other than one other hospital in the state of Virginia, Carilion Children is performing this incredible way to assess dysphagia. So clapping is totally required. So what is FES? It's the fiber optic endoscopic evaluation of swallowing. Say that 3 times fast. So it's really like a two-person assessment. So one speech pathologist will actually pass the flexible scope through the nair of our patients. We're going through the nair and into the nasal mucosa and down into the pharyngeal cavity, and you just kind of stay there while your other speech pathologist really takes the lead with the assessment part. We're actually feeding our patients and watching the structures move during swallowing. So who is our population? Who's a good candidate for these studies? Patients who present with clinical signs of aspiration during a bedside evaluation, patients for whatever reason are NPO, so we want to evaluate if they're safe to either introduce or reintroduce oral feedings, patients with known or suspected laryngeal abnormalities, and examples of that would be your vocal cord paralysis, kids with trachs, laryngeal clefts, those sorts of things. Patients with abnormal swallow study findings, we want to either, repeat an assessment of some sort. This allows us to do so without exposing that child to additional radiation. Surgical patients, post-op, an example of that would be our supraglotoplasties, for example. We have the opportunity to assess swallowing before the surgery, and we can assess it after the surgery because we've adjusted that airway on that child. And then patients that have difficulty managing their own secretions. Those are all good candidates for FES. Long list of advantages. This gives us a really clear view of the structures that are involved with swallowing. It's a beautiful, beautiful image. We have an amazing equipment that allows us to do this. It is less expensive and it's a more portable procedure. So thinking about our inpatient population, we can actually take the equipment to the patient's bedside and not have to transport them down to radiology. There's no time limit, and when we're doing a modified barium swallow, we're actually very conscientious about how long we're exposing that child to radiation. So we really want to limit that exposure. We're looking at the sensory function during swallow, like how well timed the swallow is. There's no need for barium contrast, and that's a huge deal with some of our very picky eaters. If you put that barium in their food and they're like, nope, it's not going to go in my mouth. We have the ability to look at the nasal and pharyngeal mucosa. If there's some irritation, that could be a sign of reflux. We're looking at the readiness for oral feeding, so we can really look at that kiddo that's really not taking very much in terms of volume and get a decent assessment with the use of FES. And again, we're looking at how well they're managing their secretions. This can be repeated more frequently than our swallow studies. So this is huge for us because we have a lot of frequent flyers that we really need to look at how their swallow is progressing or sometimes potentially regressing. So FES allows us to do that more frequently, and again, we're not exposing that child to additional radiation. And this is a population that they're going to get chest x-rays, they're going to get upper GI, so it's a huge deal for us. And then I haven't done this yet, but it is possible to assess an infant swallow while breastfeeding. You cannot do that during a modified. So this is just a quote pulled from research. Let me find my, it's from Reynolds in The Advances of Neonatal Care from 2016. Fiber optic endoscopic evaluation of swallowing is a safe alternative to the MBSS. It can be utilized at the patient's bedside for the diagnosis and treatment of swallowing disorders by allowing the clinician the ability to replicate a more accurate feeding experience, therefore determining a safe feeding plan, which is ultimately our goal with any swallowing assessment. We want our patients to be safe. Few disadvantages. Samantha and I have passed scopes on each other a lot. So there is a little bit of pressure when the scope is passed through the nair, but it subsides once you get through the nasal mucosa. We have, with the guidance of Dr. Cable, we have used some lidocaine spray in our older kids. It kind of numbs the area, so it kind of takes away that discomfort. Some of our kids and even our adults that we've practiced on, it can cause some gagging and, again, some slight discomfort. And during when we're actually watching our patients swallow during a FES assessment, there's a brief sort of whiteout period because the vocal cords close, so it's referred to as a whiteout period, so you lose sight of the structures very briefly. You lose the ability to really kind of get an idea of the oral phase of swallowing, so you can't really look at what's happening with the tongue and in the mouth during a FES procedure. And it is a little more challenging to stop and make adjustments if you need to. A lot of times we do positional changes that can help, with a swallow. So with that, you're going to have to take the scope out, change your position, put the scope back in. So these are just two side-by-side images. So on the left, this is what a modified barium swallow looks like. It's under X-ray. And for all my anatomy lovers, the one on the right, this is the image that we see during the FES study. Amazing. This is just a brief picture of the difference between the equipment. This is the flexible scope. We hook this into a computer monitor that gives us a beautiful picture on basically a TV screen, so we're actually seeing what's happening. And then this is just a picture, not one of our kiddos, one of our patients. It's a Google image of a kiddo down in radiology for a modified. So I'm going to close with a case example. So we have a 4-month-old infant with a medical history significant for prematurity of 34 weeks, chronic congestion, noisy breathing, GERD, a weak cry, chronic cough. Previous MBSS indicated 3 episodes of deep laryngeal penetration, 1 frank aspiration event requiring therapeutic modifications to maintain safe swallows. So would this patient be appropriate for FES as a follow-up assessment? The answer is yes. Does anything in that stand out for anyone that would make it an appropriate follow-up referral? For me, weak cry, what does that indicate? Those cords might not be working like they should, so that can impact the child's swallow. My red flags are always up when I hear a family, a parent describe noisy breathing. Let's say 8 times out of 10 when you get that child in for a swallowing assessment, there's something going on and impacting that kid's ability to stay safe with swallowing. And that's it. That's all I have.
Thank you, Kristin. Does anyone have any questions for Kristin? Yes, Alex. Where are we doing the FES?
So currently, the majority of our studies are occurring over at Riverside in our ENT department with Dr. Cable. So that population would be considered an outpatient population. As we move forward, we're going to be performing these in-house as well. So again, we can, with it being so portable, we can take it to the patient's bedside, whether it's in the NICU, PICU, or on the PEDS floor.
And we have done some in the NICU already.
Yes, we have. Dr. Keys.
presence of the scope itself, how does that modify the swelling mechanism?
I'll try to describe this as best as possible. So the scope, you're really hovering kind of in that pharyngeal cavity, so you're not far enough down to really impact the closure of the cords. So you've got to kind of find the sweet spot, if that makes sense. The gagging, if that happens, it's going to occur like as you're passing the scope through the nose and, you know, base of the tongue, sort of in that area. Does that make sense?
Yeah, I'm just thinking that's how the movement of the palate, the hypopharyngeal muscles, all that, not only just closure of the scope.
Mm-hmm.
Like if that would have some influence on that.
The scope's pretty tiny. Yeah, it's pretty tiny, and so far I haven't experienced or felt like that has impacted the child's swallow. Anyone else? Oh, I see one more.
Can this just be ordered to the computer?
Yes. You might be able to answer that more specifically, Amy.
I just tell the doctor what I need.
So right now, the way that we're practicing is generally a modified barium swallow study is a good idea from the get-go to get that gold standard, that lateral view, and then we can go FES from there. But if you order a swallowing evaluation for pediatric speech, then they will be happy to evaluate. We would never do a FES without doing an assessment first on the child. So if you order a pediatric swallowing evaluation, then the pediatric speech pathologist would be happy to see the patient and then can work with the provider to say, yes, FES would be appropriate. This is how you move forward. Does that answer your question? Okay. SLP1 in EPIC. Thank you, Laura. All right, next is Lauren Maxwell. Thank you, Kristin. One of our physical therapists and one of our 5 therapists at the barn.
Yes.
So we're going to talk horses.
Yes, so I'm here to talk about horses. Hippotherapy is defined by the American Hippotherapy Association as a physical, occupational, and speech therapy treatment strategy that utilizes equine movement as a part of an integrated intervention program to achieve functional outcomes. So the 3 main factors that help make this a successful treatment is movement is the first thing. So a horse's movement most closely mimics the human pelvis during walking. So you're getting your rotational, your lateral, and your AP movement while upon that horse. Now, each horse is different, so you have to do an assessment of the horse prior to, and then select that for the child. But the therapist can then manipulate and grade this movement by speeding up, slowing down, starts and stops, sitting forward, sitting backwards, sideways, all of that while on the horse. The next thing is sensory input. So while the kid is out there, they are getting proprioceptive, vestibular, visual, tactile, auditory, and olfactory input just from being in. So it's an awesome thing. The motivation out there is one thing that is amazing. So you take a kiddo who's been getting therapy in the clinic, possibly weekly for years, and you put them out on a horse at the barn, and their increased participation. It's amazing. So it's fun to see their little smiles. Okay. So this is an example of a physical therapy session-ish. So the therapist, or you can see in this first picture that the kiddo is having difficulty maintaining good posture when just sitting on a bench. Then you put them on a moving horse, and it shows how the horse facilitates activation of core muscles to achieve postural control through neutral spine and pelvic alignment. So he now is able to sit up straight as well as reaching for the ring in that picture. In this picture, this kiddo has right-sided hemiplegia, and he has a hard time opening his hand. Now, when you put him on the horse, he's able to utilize his core stability to gain improved digit extension. Then you can work on reaching for rings or reaching for whatever toy it may be. The OT also can address the sensory processing. So they can do brushing and different
different things with feeling and of the horse and different things there. The speech therapist uses the core muscle activation for increased breath support to improve sound production. Movement has been shown to increase language production. So you'll see a kiddo who might not be saying or making any sounds in the clinic, and then you put them on this horse, and all of a sudden they're trying things or more motivated to even just sign more or go. So it's awesome to see that out there. Patients with a variety of disorders will benefit from hippotherapy, especially those with weak muscles, impaired postural control, impaired balance responses, impaired coordination, and decreased mobility. You may have heard of therapeutic riding, and that is not what we're doing, but it is a recreational activity that provides riding lessons to individuals with disabilities. Hippotherapy is different in that it's with a skilled therapist, OTPT speech, and they have their hands on the patient the entire time, and they're using the horse's movement to utilize and elicit a desired response from the patient. So like I said, forward sitting, side sitting, backward sitting, hands and knees. I even have had kids on their in tall kneel or standing on the horse to kind of work on different muscles, so it's awesome. Therapists do this to address strength, range of motion, sensory organization, proprioceptive awareness, and attention and participation. So here's a list of our precautions and contraindications. So things that we definitely think about and take into consideration. To make a referral for hippotherapy, you just write a script for OTPT speech, whatever the desire is, and send it to us. And then we will one of our therapists will perform an evaluation who will then determine if this is an appropriate treatment strategy at that time. We do 2 12-week sessions, one in the fall, one in the spring, and we found really good results so far. But we are currently in the process of doing an IRB application for hippotherapy research. So if anybody is interested in helping with that, we would love to have you.
Thank you. And Lauren, I have a question for you while we're switching over to Laura. Laura Alexander is one of our clinical team leads, and she's a physical therapist. So just for the folks to know, we're not able just to take a therapist and throw them in the barn. Can you talk a little bit about the certification and the training that's required?
Yes. So in order to do this, you have to have, I want to say it's 20 hours of observation observation under a level 2 certified therapist, which is what myself and Lisa Beldera is our other physical therapist out there, to then start, and then you have to go to 2 5-day courses to get your hours to do it by yourself. But we are lucky in that Lisa and myself are level 2 so that we can kind of start that training, get those hours going for our OTs and our speech therapists.
Thank you. And just to continue with the plug, we are, Emily Gwill and Lisa Balderas have almost a complete proposal for the IRB. So if there's a resident who's looking for a project, we would love somebody to help us. All right, Laura, thank you.
Okay, no problem. I'm probably going to talk about the one thing people are most familiar with, which is casting. This is a program that we established within our department, our outpatient department, about 12 years ago. So it's something that we've been doing for quite some time. We're just making people more aware of it locally. So most of you, if you've been through any sort of medical school, have actually casted somebody, so you're aware of all of those things. But why do we do something as specific as serial casting? So this isn't casting for a fracture. It's really about trying to stretch something out. So we do these for up to 8 weeks at a time, as long as the child can tolerate it. We don't have skin issues. We have family compliance as far as showing up, because they do need to show up about once a week. And we try to get that scheduled so it's consistent with the patient and the parent and life. And we keep it going until we either stop seeing results or we get to 8 weeks of casting. And some of those things is we're not just stretching out the muscles. We're stretching out all of the blood vessels that are going across the joints, the nerves, all of those fascial layers, and the joint capsules. So we always talk about it as about stretching out a muscle, but we have to consider all of those other things are also being moved in there. We do change it typically every 7 days for some of our populations, especially with our kids with muscular dystrophies. We don't want them casted for long periods of time, so the newer research out there is saying, hey, change it every 3 days and then they're out of their casts in under a month instead of 2 months, and we still have them up and moving, and we're not creating weaknesses where we don't want them. And then we always make sure that when we are finished casting that we are following up with some sort of overnight splinting to maintain those stretches. We've got the orthotists on board. They'll come at week 2 or 3 of casting to fit them for new braces. So literally they come out of their casts, and before they leave our clinic, they're in their new AFOs or braces and walk away in those. So we've got all of those coordinated and ready to go. And we want to make sure that these kids are also getting therapies, not only just with us, but we've coordinated this with local therapists. When I say local, we know local for Carilion Children's is within 2 hours away, that they're getting ongoing services while this is happening, and this can be part of their overall therapy plan. So why do we do it? We know that there are lots of reasons that kids get tight, and we know that this is one of the ways that we can help them get untight. And there's lots of theories about why it works. One of the reasons we know these parents are very overwhelmed for kids with lots of medical appointments and lots of needs. And we're just saying, you know, just stretch for 2 or 3 minutes a day. That 2 or 3 minutes, you know, that might be getting a bath or getting dressed or actually going to bed. So this is one way we can increase compliance with that prolonged stretching, because the kid can't take it off, the parent can't take it off, so we know we're going to get that stretch for a long period of time. We also get kind of that low-load, prolonged stretch, so they're actually seeing changes in the sarcomeres at the muscular level. We see cellular changes. We get actual elongation of the muscles in there. And then for our kids who are hypersensitive, it provides kind of a safe, warm environment, so they're not getting that sensory input and causing to kick off that stretch reflex all the time, every time they're standing up. One of the other things with serial casting is we actually want these kids up and moving. So we've got kids riding bikes. You know, when the parent comes in, they're like, oh, we went to the trampoline park this weekend. Well, the trampoline park's bad for all sorts of other reasons, not so much the serial casting, but we want the kids up and moving and active. So they are casted well enough that we expect them to just return to general life while they're being casted, especially with their legs. So what are we trying to do with it? Our goal is to get full range of motion at all joints. And we are doing hips. We're not doing hips or shoulders. Those are the two we don't do. But we are doing knees. Primarily we do ankles, but we'll do elbows, we'll do wrists, we'll do fingers. All of those things, they're all joints, they all have muscles, they all need to be stretched out. So we are stretching across all of those. And these are some of our pictures of the kiddos we're doing. So we've gone as low as 2 weeks of age. For Ponseti method is a form of serial casting. If you think about it, it's changing casts over and changing ranges as you go, up through 18 and kind of across all of those joints. And then if we can get that increased range of motion, that we know that we can turn that into functional gains. So we can turn that into something else. We're not getting straight functional gains from the serial casting itself. We're getting a body system change on that, but we can turn that into functional stuff. We know that most of these joints, making sure you've got a good understanding of anatomy, that some of these times you need to cast more than one joint. So if we're looking at a shortened gastroc muscle, it crosses 3 joints, so that's not just an ankle cast. We may also have to include the knee in that so that we're getting stretching across all of those. Getting a parent to buy in that we're going to cast your kid from basically their hips to their toes and have them walk around on it is kind of fun, and they always say that they get lots of odd looks when their kid's walking around Walmart on a long leg cast with no crutches or anything else. But you know what, we'll get the parents to buy in and get all of that motivation. One of the things that we do differently with a lot of our casting is we use a variety of materials. So we know that we are treating children that a lot of times have other sensory needs, and a cast saw is scary. Not just to look at it, but to hear it and feel it. So we have other materials that we can use to help with our casting. So we have 2 different, so our regular casting fiberglass we can use, and then we also have a conformable one where we can actually univalve it, so the parent could take it on or off if they needed to, because it's a flexible cast even after it dries, but it has a rigid stay down the back like a bracing would. The other one we can use is a type of soft cast material which actually goes on like regular fiberglass, hardens like regular fiberglass, but it peels off like an ACE wrap or an elastic wrap, which is really nice for those kids who cannot handle being around a saw, or for our families who live 2.5 hours away and their access to an ER to get a cast taken off, say like if they jumped both feet first into a pool, because that's happened, because you know kids are kids, that the family can unwrap it at home and take it off. Also helps for our kids who are trach prevented, that we don't have fiberglass particulate flying around as we're trying to remove a cast. We can use that soft cast material for that. So we have lots of opportunities and options to make sure that they're successful. So how do we know that we should do this? This is 30 years of research. In the background, it's kind of past 20 years, it's been a standard of care. This is a systematic review of systematic reviews, so I don't know how much more deep into research you can get that green lights that this is one of the things that we should be doing to change body systems on our patients. It's actually the only thing we have that's a green light saying, yes, we should be doing it. So that's on, we know we should. So how do you get to us? Same thing. If it's something that you think this might be an intervention for, referral to PT, pediatric PT, we will do an assessment, write it in our plan of care. You will get an extra request for a script because Carilion considers this an invasive procedure. So you will get another prescription saying, hey, sign off saying that you do want us to serial cast. And we coordinate this a lot with our PMR physicians and our orthopedics around here to coordinate it as far as Botox injections in regards to timing. And because this program has been around for a period of time, it is recognized regionally as a place of referral sources. So we've had referrals from Shriners, from Dukes, from Johns Hopkins. We coordinate care with UVA, had referrals from CHKD. So they know if there's a kid within a couple of hours of us, we are the place that they're going to send them to get this done. I talk fast.
Well done, Laura Alexander. Next is Samantha Litz, who's going to talk about our baby bridge. She's a speech pathologist. Any questions for Laura? There was a question on the phone for speech.
Sign language for children with cochlear implants, the study, SLS.
So what is the impact of sign language on children with cochlear implants? That study, you go, Tara.
9%, 70% difference. What is that for normal hearing children and parents just?
Okay, so you're asking for a normal hearing child, what is the impact of using sign language? So that is something that we do often encourage because children imitate motor movements before they imitate speech. So that is actually a great way to bridge to get to verbal communication. So I would say that's a totally different thing and, yes, something that we would encourage. But for children with hearing loss, we really want them to develop those listening skills. And so if there's an easier way of a sign in front of them, then they will rely on that. Thanks.
Thank you, Tara. Take it away, Sam.
All right. So in looking at some literature, I found a study that was conducted in 2017 that found that there's a lapse in initiation of early intervention services in patients that are discharged from the NICU. So on average, these infants were waiting up to 9.5 months before services were initiated for physical therapy and up to 20 months waiting for services to be initiated for speech therapy. This is a significant delay in a population that we know are at high rate to have developmental challenges. There was another study conducted in 2015 that found that very preterm infants with feeding difficulties within the first 2 years of life have a poor cognitive, language, and motor functioning at 2 years compared to the very preterm infant child without feeding difficulties. So after we identified that there is a need for initiation of therapy services sooner, we decided to establish our Baby Bridge Clinic. And the purpose of this clinic is to provide a transition from hospital discharge to ongoing services for infants who need skilled therapeutic intervention to address crucial skills. Our criteria may include any of the following: infants 0 to 6 months of age, documented airway violation on a modified barium swallow study, inability to complete efficient PO feeding regarding discharge with NG tube or G tube, or difficulty demonstrating atypical tone reflexes, positioning or state transitions which impact calming, sleeping, or feeding. So in early intervention, the agency has up to 45 days from the referral to complete the evaluation and initiate the Individualized Family Service Plan, also known as the IFSP. Then they have 30 days from that evaluation to locate a provider and initiate services. Currently in the Roanoke Valley, there's a long wait list of patients that are waiting to receive speech and feeding services. An example of this is a patient that we had that was discharged from the NICU who required TPN and G-tube feeds. His early intervention services were not initiated for speech therapy until 6 months after he was discharged because we were unable to locate a provider to serve him. We were able to see him in our clinic within 2 weeks to get the ball rolling. So we collaborated with the local infant toddler connection of the Roanoke Valley to establish this clinic, which will bridge the gap from discharge to home services. Our services are highly specialized because of the nature of the complex feeding and gross motor challenges that our patients have. We schedule our appointments within 1 to 2 weeks upon discharge, and then once an early intervention provider is available, then we often transition these patients to early intervention. We started our clinic in March of 2018, and we currently have 2 to 3 patients that we evaluate between speech and physical therapy a week. Most of our referrals are from hospital discharge, but we also get referrals from outlying physicians' offices on patients that meet our criteria.
Great job, Sam. Does anyone have any questions about our Baby Bridge clinic?
No.
Yes.
What's the geographic area that you cover?
Well, that's a great question. So we've had patients come all the way. I've had a patient from Radford come to this area. I think it just depends on what the patient needs specifically. We've found that some of our patients that are in very rural communities aren't receiving the access to care or the type of care that we might be able to provide. So if we see them first, then we can help kind of coach or guide the therapist in their area to continue that care.
Great question. Anybody else? Mandy?
So this is treated just like a traditional outpatient evaluation. So we run all the information through their insurance, and it's covered that way. Early intervention, the evaluation is free, but there is a sliding scale and ability to pay assessment at the evaluation.
And a good thing with our collaboration with the local early intervention agencies and the surrounding early intervention agencies, they can use our note as their entry into EI. Any other questions for Sam? Okay, thank you. All right, I have questions for you. So which would not be a criteria for Baby Bridge Clinic? A 4-month-old child with failure to thrive, having difficulty with bottle feeding, an 18-month-old with strong oral aversion, a term infant with neurological deficit, or a former 34-weeker? B, I normally have candy to throw at you, but I got nothing. Which therapy intervention might be appropriate for a 2-year-old with CP with poor postural control who has a goal of independent sitting? Hippotherapy. Good job, Dr. Keys. The period of greatest neuroplasticity of the auditory cortex is during the first what years of life? A, perfect. On the evidence alert traffic light, what level is serial casting to address body systems for patients with CP? Yay, green. Which of the following describes functional E-stim? Used for muscle strengthening. Is task specific to improve a skill activity or must elicit a motor contraction? We want it all. All right. Any questions? We good? Okay. Alex is going to open up the phone.
If you're on the line and you want to ask a question, you will have a chance in just a second. If you do not, just please put your phone on mute now.
The conference is now in talk mode.
Does anyone on the line have a question for any of our presenters or want to make any comments?
Amy, this is Dr. Hart. Great presentation. Kudos to your team. I was off the phone for the last 5 minutes, but can you just briefly bring us up to speed on where we stand with augmentative communication using iPads and other modalities of those kids who are sort of locked in cerebral palsy, who truly do not have very good vocalization? Where do things stand with that? I know it's a talk on itself.
That's a great idea for grand rounds, Dr. Hart. Thank you for that. So for our kiddos who have who are nonverbal, there are lots of expensive speech-generated devices that are exclusive to kiddos with communication disorders. They run $5,000 to $8,000. We currently are in the process of having 10 iPads in the department that have been donated. Thank you, Child Life, and downloading on them, not Proloquo to Go, LAMP. So LAMP, L-A-M-P, is a communication program that works based more on motor learning and facilitates language in kiddos. So if you have a child that you feel like would meet that need, certainly refer them for speech evaluation to our department, and we do have people who have that as their clinical expertise.
Yeah, I'd like to suggest that for future grand rounds. I think it'd be a really instructional.
Yeah.
Great job.
Thank you. Any other questions?
Amy, this is Amy Kreider.
Hey.
Hi. I had a question about fees. I have a little girl in my practice with ataxia telangiectasia that, so radiologic tests are relatively contraindicated if you can avoid them because they have got an increased risk of cancer lifelong with that disease. Her AT center has been reluctant to do a modified barium swallow because of it, but I think she's got some choking with eating. Would FES be a good option for her? I'm not sure if it's her glottic function or her oromotor function.
So, Dr. Kreider, this is Kristin Winslow. I would absolutely recommend FES for her. A great place to start with her, if she hasn't had a clinical feeding evaluation, would be to start there, and the therapist from there can make recommendations to the therapist that would perform FES for her.
All right, thank you.
So, absolutely, yes.
Thank you for that question, Dr. Kreider. Anybody else?
All right.
Thank you.
Okay. For everyone on the line, if you do have a question or want to make a comment to any of our presenters, you can always email us at outreach@carillionclinic.org. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.